Okay, we can get started then. Good morning, good afternoon, and good evening, depending on where in the world you're connecting from today. My name is Ann Lang. I'm the Executive Director of PHAP, that's short for the International Association of Professionals in Humanitarian Assistance and Protection. I'm delighted to be serving as your host today for this webinar entitled Operationalizing Standards, Sphere and the COVID-19 Response in Camp Settings, organized by the Camp Coordination and Camp Management Cluster, CCCM Cluster, and PHAP. Now, this is clearly a topic that is engaging a lot of people today, and it's great to see so many of you, not only in the main event room here, but I understand we have more than 500 people right now on the live stream channels, which is fantastic. We actually had more than 2,000 people register for today's event, and so that's why we've been emphasizing the live stream. So thanks so much to those of you logging in, no matter how you're logging in. It's great to be able to bring everyone together, and we're looking forward not only to today's 2-hour discussion, but also future opportunities to bring you all back together again as well. This will be an ongoing discussion over the coming weeks. Now, all over the world, everyone's focus is currently on the novel coronavirus and COVID-19 and the effects it's having on health services and both global and local economic systems. People are, however, affected differently by the current situation. Some are, of course, more vulnerable than others to both the illness and the overall disruption. Among these, displaced persons are often especially vulnerable. They are the focus of this webinar, where we will be looking at preventative measures taken to protect them from COVID-19 and how we respond once there is an outbreak in the population. While displaced people will be living in different types of contexts, to help us focus the discussion today, we're going to be looking in particular at camp settings, planned camps, unplanned camps, collective sites, and transit centers, and how we can apply technical guidance in standards to this new situation. For those of you working in other types of response contexts, I hope that you'll be able to draw some relevant lessons from the discussion today. The CCCM cluster will then be organizing additional webinars related to COVID-19, which will be looking more at area-based approaches and other types of responsibilities for camp managers. We have already received many questions from you in advance, and we'll be covering a lot of these in the discussions today. But again, I do encourage you to really engage in real time in the discussion, in the chat, and also to submit new questions, especially reacting to what you hear from our speakers and what you see in the chat, what you hear from your fellow participants. So please do submit additional questions in real time throughout the event. We'll cover as many as possible during the event, and for those that we don't have time for in the live session today, we will be following up with the speakers afterwards to see if they'd be willing to provide an answer in writing that we can then share with you and with all of the registrants as an ongoing resource. So in today's event, we'll be looking at standards and how they provide guidance for response in camp settings in the new COVID-19 operational environment that we're all facing. In particular, we'll be looking at the Sphere standards, and we'll be hearing from Aninia Nadig, Policy and Practice Manager at Sphere, about the overall relevance of the standards and the recent COVID-19 guidance published by Sphere. Welcome to you, Aninia. Great to have you on the line.
Thank you. Thank you very, very much. Happy to be here.
We also have two of the lead authors of the WASH and Health chapters of the 2018 revision of the Sphere Handbook on how these standards translate into our current reality. We're joined by Judith Harvey, currently a practicing clinician in the UK National Health Service, who was lead author for the Health chapter. Welcome, Jude.
Good morning.
Good morning to you. Also, Kit Dyer, WASH advisor with Norwegian Church Aid, who was a lead author for the WASH chapter. Welcome to you, Kit.
Morning all. Good to see you, literally.
Yes, yes, indeed. Great to have you virtually here with us. And also together with Antonio Torres, Global WASH Coordinator with IOM. Welcome, Antonio.
Thank you. Hello, everyone.
Great, great. Glad that you're connected, Antonio. Also, an important aspect of the response in camps is how we engage communities. And I'm very happy to have with us Virginia Moncrief, acting response manager at Translators Without Borders, who will help to give us some overall pointers in this regard. Welcome, Virginia.
Hi, thank you very much. Glad to be here.
And importantly, all of the guidance needs to be applied to fit the local context. We'll also be hearing from camp managers who are currently facing COVID-19 in the camps they're working with, from which we'll hopefully be able to draw inspiration for how we act in our own response context. So in that regard, we have with us Manuel Pereira, Deputy Chief of Mission in Bangladesh with IOM. He's working on the response in Cox's Bazar, but connecting from Bangkok due to the travel restrictions. And we're still working on getting that connection. We believe he's had an emergency come up, so hopefully we'll be able to bring him in very shortly. And we do have on the line Richard Okello, CCCM Cluster Coordinator in South Sudan. Welcome, Richard.
Thank you. Good morning, everyone, and nice meeting you virtually over this screen.
Indeed. Good morning and welcome, Richard. And connecting from Iraq, we have Sibila Kitsios, camp manager for the Salamia camp with ACTED. Welcome to you, Sibila.
Hello, everyone. Very happy to connect with everybody and share experiences.
Terrific. Thank you, Sibila. And finally, we're joined by Derhayo, Senior Durable Solutions Coordinator with UNHCR, and previously the Whole of Syria Coordinator for the CCCM Cluster. Welcome, Der.
Thank you very much, and glad to be here.
Terrific. Thank you. Now, so to set the stage, and there I'm going to stick with you, I'd like to turn to you first. What can you tell us about what is happening in Syria right now in terms of the camps in this new context of COVID-19?
According to the latest information on the displacement inside Syria, we have more than 6 million internally displaced persons. The camps are scattered all around the country, of which the humanitarian actors are facing immense difficulties to access and to provide services physically in these camps. So in this, we are mainly focusing on the areas where we are able as a cluster and the cluster members to provide assistance, and I'm referring in particular to these camps that are located in northwest Syria, in Idlib Governorate, which is already a very intense conflict zone. In Idlib Governorate, there are 3 million people, of which nearly half of them are internally displaced people. And out of this, more than 1 million internally displaced people, nearly 700,000, which is 1/4, are living in these IDP camps. And as you rightly said, that the camps go beyond the classical definition. Most of these camps are self-established containers, so they lack the minimum capacities to respond to any emergency situation, such as COVID potential breakout. Some of these camps are running beyond their reception capacities by 400%. So they are very much overcrowded, and the reception and the services are highly overstretched in these locations. The humanitarian response is done remotely, and gradually it has become more and more remote from 2013 onwards. The assistance is provided through international borders from southern Turkey, and the coordination is based in southern Turkey, both clusters and the key organizations. The staff of the organizations, largely grassroots local organizations, are based inside Syria, where they translate the assistance that we provide from here into actual services inside these camps. Now, what we are doing and what's happening with regards to the response currently, we are translating the standards into operationality. We have been setting all the possible scenarios and preparing contingency stocks inside these locations and in the vicinities of the areas. In some of the camps, in particular, we are referring to the reception centers where the IDPs are living jointly in large tents that we call rub holes. These basically we are prioritizing to evacuate the IDPs because in case something happens, it will be nearly impossible to control the situation. In the meantime, we are working closely with the health cluster and their actors, in particular health services. In many of those locations are not located inside the camps, but in the area, whereby we are informing the health service providers about the situation in the camps, numbers, and explaining to them the vulnerability, the specific vulnerability of the camps. We are, which is most importantly, building strong communication with the population of the camps and with the host communities, because it is very normal that when we don't have access, the host community and the health actors and de facto authorities could consider these camps a threat because of their special situation. Again, we cannot ensure how communication is important in these kind of circumstances. We, of course, will also be on health. We work very closely with the water actors to ensure that the scenarios are in place in case we lose completely access, and there are possible ways to reaching those IDPs. We are definitely working with health cluster and the food cluster to try to restock some items. There are, when possible, some large tents are already established by the specialized partners of the cluster and health cluster to be ready for any potential breakout, hoping it will not happen, but to be ready to respond in case there is a need. Over.
Great. Thank you so much, Der. We've received a number of questions, including from Danielle in Chad, now from Gulam in Pakistan, Faye in South Korea, Eric in the US, Patrick in Zambia. All of them are wondering about the new access situation to camps in the context of COVID-19 and how to manage remotely if access is not possible. I hear that you have you do have experience in this regard, of course, and this question will be a thread throughout the event, but I'd like to ask you first, as you have been remotely coordinating partners working in camps in Syria, what would you highlight from that experience as lessons or wisdom that you could share with those working in other contexts who may now have greater access restrictions for the camps that they're working with in the COVID-19 context, whereas they didn't have such restrictions before? How have you seen things change, and really what, briefly, what would you highlight that could be lessons that could be taken to other contexts? Over to you.
In this situation, it is important to make sure that the standards and the messaging is tailored to the remote management context. The key slogan that all of us are using now with regards to COVID-19 situation and where we see everything is stay home. And in camps, unfortunately, this is very much irrelevant because the definition of home is very different and the people are not going to survive if they have to stay in the camps. For us, with the lack of access, we have to make sure that beyond the management, only the coordination is basically maintained and tested to the extent of possible to make sure that if we are going to lose the access completely, these tests and these contingencies are going to operate independent from us. This is going to happen mainly not only through us and through our partners, whereby we might lose access, but also by setting very close communication channels with the residents of the camps and with the focal points inside these camps. Testing the services becomes extremely important because you don't want to find yourself missing some key critical aspects when you completely lose access. So again, I cannot emphasize enough on testing all communications, on testing that all the areas where items are pre-stocked are reachable for the IDPs, in making sure that the key life-saving assistances are not cut from these camps. Also, from the coordination perspective, and here the role of the camp coordination and camp management cluster and its members become vital to make sure that you maintain close contacts with the other clusters, because the situation in the camps, again, might be very much different. People out of the camps have the privileges and the capacity to stay home. The camps will not apply these rules because people have to go outside to access food, basic services, and anything else part of the small shelter that they are staying in. It is important to continue and test the services in terms of communication with the host communities and the de facto authorities in the area to keep explaining to them the situation in the camp. What is most important, again, keep yourselves always ready to receive the information because once you lose the direct access, the information will be the only way for you to tell what would be next and which kind of services you have to consider providing in these camps when there is a remote management context. This was basically the experiences that we have had for Iraq when the access was not possible in the past period, Somalia, and for Syria currently. Over. Thank you.
Great. Thank you so much, Dara. That's very useful indeed. Now, to continue on this path of helping to orient our participants, I'd like to just briefly turn to our colleagues on the line who are working in other camp situations. I'll first turn to Sibilla. Are there any confirmed COVID-19 cases in the country where you're working, in the camp where you're working, and what kinds of measures is the government putting in place that are affecting the camps? I'll turn first to Sibilla and then to Richard. Over to you, Sibilla.
Yes, thank you very much. As of this morning, the Iraqi Ministry of Health has confirmed 728 cases of COVID in Iraq, with 52 fatalities and 182 patients who have recovered from the virus. Inside our camps, we currently do not have any cases confirmed. The government of Iraq and the Kurdish regional government were quite quick to respond to the confirmed cases, and they have extended curfews and movement restrictions until the 19th of April. The Iraqi airport is currently closed, and at present, all the major airlines have suspended normal passenger operations to Iraq. The Minister of Health has also called upon Iraqi citizens to be proactive in coming forward if they have flu-like symptoms, stating that the majority of fatalities have occurred due to delays in seeking medical attention. They also have established a hotline that people can call, and there has been a new laboratory opened in Baghdad for the testing of COVID-19, which adds to the country's medical capacity. In Iraq, the first case of corona was confirmed on the 24th of February, and the Directorate of Health was quite quick to respond to this. They visited our camp 3 days later to provide awareness sessions on the virus to camp representatives, interested residents, and staff. And the DOH, the Directorate of Health, also informed active camp management about several measures that must be taken, given that the infection of the virus inside Iraq had been declared, such as restriction on movement. Based on this and from input from the CCCM Wash and Health Cluster, we then developed a 4-phase response plan, which in the second phase included a response to a suspected case in camp. We had that once, and we immediately informed the Directorate of Health, and they came with the support of our health partner to sterilize the camp. The Iraqi Ministry of Migration and Displacement has also created a WhatsApp group with all camp managers and health actors in the country to be able to coordinate between each other fast and quickly respond to the situation. And an interesting point also is that we had some shop owners inside the camps during the lockdown of the country, such as in many countries around the world. It was difficult for IDPs to move out of the camp to the markets in Mosul and nearby villages to stock up their markets and purchase items such as vegetables, fruits, and milk that usually are not available in the family food rations that we distribute. We then quickly raised this concern to the mayor, and he provided a facilitation access letter for these individuals to be able to stock up their markets outside and come back with the supply so that IDPs could still purchase the vegetables, for example, inside the camp during a lockdown. As of now, as I said, we don't have any confirmed cases in camp, but in the region of where our camp was located, we had 5 confirmed cases. Today, this morning, I received a phone call from our health partner saying that the first tests have been negative, so the patients are recovering. In 24 hours, we will know. There will be another diagnostic test, and we will know if the patients, indeed, all 5 have recovered, making the region, the area of where our camp is located, free from corona again. Thank you very much.
Great. Thank you very much, Sibila. And could I turn now to Richard? So same question for you, but different context. Could you tell us just briefly a bit about the current situation where you're working in South Sudan? Are there confirmed COVID-19 cases? What kinds of measures are in place, etc.? But briefly, over to you, Richard.
Thank you very much. Hi again from South Sudan. South Sudan, as of today, there is no known case that has been declared. So the actions that have been taken by both the humanitarian and the government are preventive measures. We are well aware that South Sudan does not have the capacity of diagnostic. They cannot be able to respond to any cases of COVID. So right now what has happened, the airport has been closed, all borders connecting to other neighboring countries, because all the neighboring countries in South Sudan have all declared COVID. But we're only lucky that there's no known case, so the borders have been closed. The bars have also been closed, including restaurants. You can only take home. Going back to the displaced population, South Sudan has 11 million people, but out of these, 1.3 are living in displacement locations with the really highly congested living situation. So briefly, that's all about South Sudan. I'll come back later on to discuss what we're doing as camp management and the cluster. Thank you very much.
Great. Thank you, Richard. Now, I'd like to check if we have Manuel on the line. Could we test if you're there, Manuel?
Hi, can you hear me?
Yes, loud and clear. That's terrific. So, yes, so perfect timing. I'd love to turn to you now for this kind of framing, orienting our participants on the situation in different locations around the world. Could you tell us a bit about the situation in Cox's Bazar regarding confirmed COVID cases? What kinds of preventative or mitigation measures are in place? Over to you.
Thank you. Thank you so much for that. In Cox's Bazar, the first cases have been identified on the host community, not in the camps. But as you may all understand, there is fear among the refugee community and among the host community. So the arrangements made for social distancing and trying to create measures to mitigate spread and increase awareness are clashing with the restriction of freedom of movement of the refugees and the negative perceptions and bias against humanitarians and refugees. The military has now put a very strong control access to the camps. There is a pressure to reduce as much as the operations and access of humanitarians to the refugees. So it's quite concerning at this point. The lack of understanding of the work that needs to continue and which is the work that could actually be halted. which diverts us also from trying to provide some resources in mitigating the situation with the host community. It's a quite complex situation.
Great, thank you for that, Manuel. And just a note to our participants now, if you have questions, as you can see, we have covered a number of different specific contexts here, and we have great resources on the line in the form of Der, Manuel, Sibylla, Richard. If you have questions for any of them regarding the context where they're working or have been working, please post those in the Q&A, and we'll be coming back to all of them, of course, later in the session, so we can pose some specific follow-up questions there. So now turning at this point to how we respond to the current situation, we all come across standards of different kinds in our work, but the Sphere standards stand out in the humanitarian sector with widespread familiarity and practitioners across the sector referring to them. Aninia, turning to you, the latest revision of the Sphere Handbook was in 2018, and I assume that there was no pandemic of this scale primarily in mind when drafting the guidance. Could I ask you then, what guidance can Sphere offer in the COVID-19 operational environment? Over to you, Aninia.
Thank you. Thank you very much. And I'm happy to be here. I'm going to bring in quite a different perspective from what we've just heard. It's very intense and humbling to hear what's going on around the world at this moment. Yes, the Sphere standards have been published in their current version in 2018. No, we didn't have a COVID-19 response at the time, but we do, I think, we did learn from in particular from the Ebola crisis. And thanks to our WASH and health authors, we have stronger and more visible guidance on community engagement in the handbook now than we did before. And I can walk you through this a little bit. I will stay at a very high level and can then go into more details if you like. On the next slide, yeah, I have yes, thank you. On this slide, I want to show you how we went into the COVID-19 guidance that we've developed a few weeks ago and which had a lot of uptake. The starting point was to say you cannot do a response like this if you don't have people and communities on board. And there are three arguments to this. The first one is that you need to treat people as individuals, as humans, and not as cases. And this element of human dignity is very strong in the humanitarian charter. Now you might say, well, the charter is just something aspirational and relatively abstract, and I would like to say that elements like the humanitarian charter or the protection principles, which we'll get to in a minute, are particularly important when it comes to a situation like the COVID-19 response. The humanitarian charter mentions the three key rights, which are the right to a life with dignity, and in a health situation, it's also the right to death with dignity, which goes all the way to the new palliative care standard in the handbook. It's the right to receive assistance, and it's the right to protection and security. And all those are key rights that we need to uphold and address as good as possible in this response. The next element is the community engagement, which is key in the WASH and health chapters, but also in the others. The WASH chapter has the strongest focus on it because it works so much on hygiene promotion, and that is key to this response again. Then thirdly, we mentioned the fact that you cannot just work on a COVID-19 response. You need to maintain all other aspects of health and of health and other needs of people as well. And that is where psychosocial support, palliative care, and all other standards in the handbook are of critical importance, and we may not lose that perspective. On the next slide, I want to discuss briefly the three elements that Sphere brings together and which will help you in your response. The first is, again, the community engagement. The second is technical standards, technical knowledge. And the third is contextualization and coordination, and here specifically in camp settings. And community engagement and a technical good medical response, those two are key factors for a public health response. And in that sense, I would argue that the Sphere Handbook is a very good tool for any public health intervention. Community engagement, we've seen it, we've touched upon it. It's about hand washing. It's about the engagement, the exchange with communities, knowing where communities are, knowing where the people are and what their needs are. Technical standards in terms of the COVID-19 response are, in particular, the hygiene promotion standard in WASH, standard 6 of the WASH chapter, which talks about WASH support in disease outbreaks, and which is a very good example of WASH and health sectors working together. And then actually all health standards, but in particular the whole, the first part, and then the communicable disease response section. Those are the important technical standards. Then context and coordination in camp settings, we're going to get back to that in a minute. I wanted to go to the next slide though, because you'll find it in the WASH introduction chapter, in the introduction to the WASH chapter, and it really brings together the three key elements of community engagement. In the white part on top, the three white boxes talk about analysis. It is context, people, and behavior and practice. You then have the light green squares on the right. They are specific to programming. It's about information sharing and communication. It's about capacity building with staff, partners, communities. It's about accountability, welcoming and addressing complaints. It's about participation. It's about monitoring, evaluation, and learning. And then the external engagement are the two darker green squares on the left: advocacy and coordination and collaboration with national, international, local actors. Here you also see a very strong connection to the core humanitarian standard and its 9 commitments, which are now part of Sphere and which also directly influence community engagement and your technical work. What I wanted to mention also is for this integrated approach is that the technical standards are a direct expression of those rights of community engagement that we see in the first part of the handbook. You cannot do technical work according to Sphere without stumbling over guidance again and again about inclusion, about communicating with people. And that makes the handbook as such quite a coherent tool. In the next slide, I want to briefly mention the importance of Sphere for camp management. First, the context. I mean, we've heard now a few contexts where you are working to fight the COVID-19 outbreak. Context is so important. These are global standards that express globally agreed rights of people, and you need to put those into context. I don't have the time now to do that specifically, but what's so key for your situation is the coordination. You have the camp management role that needs to work with all sectors, with local authorities. We've seen that, and that needs to really break down those silos between different technical sectors. You see them in the handbook as as kind of silos, because simply the handbook is a continuous, you know, it needs to group the information along chapters, but to really work with all together and come to a joint coordinated approach so that you don't hinder each other but support each other is really key. The other thing about contextualization, which you know better than I do, is that if there is a real problem in one sector, you may have another sector that can come in and support. And here you see that shelter, food security, nutrition that I haven't mentioned so far are completely part of this response that you need to be doing. And this is where Sphere can help, and I would like to end with this. Sphere will give you this common language that you can agree on, even though you may feel that the standards are impossible to reach. It still gives you a common language, common benchmarks that you need to develop, and hopefully in that sense a more coherent approach, and that Sphere should support you in the holistic approach that you need in camp settings. Thank you.
Thank you so much, Aninia. I have a question that's just come in from Madeline in DRC. Madeline writes, will the ongoing pandemic affect drastically our way of working, including our standards? She writes, I want to believe that the pandemic will stop like other recent sanitary crises we had previously, HIV, Ebola, and the SARS pandemic, which did not affect the standards. But what will be the impact of COVID-19 on the Sphere standards? Over to you for any thoughts on this, Aninia.
Thank you. Well, I'm certain that this pandemic will influence the standards. What the standards can do is build on past knowledge, on accumulated knowledge that builds on past events. And I would say that HIV and Ebola have found their way into the Sphere Handbook. There is a section on HIV in the health chapter. There's a HIV standard. And Ebola, as I said, has really brought forward how to respond to a disease outbreak, and in particular, how important the community engagement is, because otherwise, if people don't trust you, if people don't engage with you, you cannot, Ebola showed that you cannot do a proper response. SARS, probably a bit less, but Ebola and HIV, I think, are in the handbook. And so will COVID-19 be in the next iteration.
Great, thank you very much. Now, we have another question, but I'm going to use this question to pivot, I think, over to Virginia. So the question is from Ramesh, who writes, this emergency is different from others, as we're all saying we need to keep social distance, But in this scenario, how can community engagement be ensured if we're trying to keep social distance? Any approach or way out of this dilemma? So it picks up on points raised by Aninia on community engagement. And so to stay on this topic and respond to this very timely question from Ramesh, Virginia, can we turn to you and ask, looking at COVID-19 more specifically, why is community engagement important in a crisis of this type? How do you see the role of camp managers in this regard? And just wondering if you have any reflections on this challenging question raised by Ramesh, this apparent dilemma between social distancing and community engagement. Over to you, Virginia.
Well, first I'd just like to say that I think that camp management have a really unique ability to have a really strong cross-sectoral overview of people's needs and their concerns and the needs of community engagement during something like COVID-19. This became really clear to me when I actually had spent years working in the AAP sector and then went to work for IOM in Bangladesh for 18 months. And it just became incredibly stark to me, the unique ability and insight of camp management teams to work in community engagement, to have an insight into the whole of camp needs, and to meet the real obligations of leading in coordination and ensuring community engagement strategies are transparent and effective. In terms of the way we approach COVID-19 in camp settings, it is a challenge given a lot of people are working on skeleton staff, a lot of people have withdrawn a large amount of staff, and that we know that most of the people who live within those camps really prefer face-to-face communication. So you've got a double whammy there of sort of communication issues that you're trying to look at. I think that a lot of ways that people are doing community engagement at the moment can actually be effectively recalibrated for this crisis. Turning to loudspeakers, for example, and using sort of USB and recorded messages across the camp so that there is a consistent and updated system of people receiving a unified message is one of the things that sort of springs to mind, and I think will just be really very simple and effective. One of the most important things, I think, though, is making sure that you collect the information from the people on the ground as to what they're hearing. And if you are even going to set up, even tomorrow, you can set up a WhatsApp group of your skeleton staff in the ground, and they can just continue to feed back to you what is being said and what people are thinking, not necessarily rumour tracking, but just where people's belief systems are working and what their fears are. You can really start reorganising your programming and repurposing your programming. Just one other thing I want to say while we're talking about this is that obviously we know that you have to involve the community as the main drivers of information. And so we have to always be really concerned about language. Information must be delivered in a language and a method that enables people to make the best decisions for themselves, their families, and the camp community as a whole. And this may not be such an issue in places like Bangladesh, where you have a camp full of people who speak mainly one language. But I've just spent a year in northeast Nigeria, and there you have camps where people are speaking in 5 or 6 different languages in one camp. So if you don't take language into account when you're dealing in that kind of camp setting, you're really setting yourself up for a failure. And you're also possibly setting up whole communities for stigma if they are not following kind of instructions that everybody else has got about social distancing and appropriate behaviour. They haven't received that information, so they're behaving differently from everybody else in the camp, and also they may become infected. So that's a whole other reason, obviously, other than the sheer, human Sphere standards of making sure that people are receiving information in a language that they understand.
Great, thank you. Thanks so much, Virginia. Looking globally at camps in different contexts, what would be some of your main recommendations for what practitioners should keep in mind in the COVID-19 response? There are a number of participants wondering about this. I see, including a question from Maria in Spain, simply wondering about your key recommendations when looking at different contexts. Back to you, Virginia.
Well, obviously, the key recommendation from Translators Without Borders is make sure that people have the information in a language that they understand, and that you utilise national staff and community mobilisers within your camp to make sure that that information is shared with people in a way that they completely understand and are relaxed with the delivery. I think with COVID-19, one of the things that accept information and the way they act on it. And so therefore, when we're talking to people, we really need to be honest with them. We need to make people alert and realise that they need to take specific action that may turn their daily routines upside down, and which they may consider sort of urgent or kind of something that they're not really comfortable with. So we need to kind of make sure that we indicate that there's an urgency within the action, but we don't panic people so much that they're completely immobilised or they act irrationally or they act dangerously. So I think it's that balance of not reassuring people that everything is going to be okay and that we've all got the answers and that everything's under control. But also not being not being worried that, you know, that sometimes fear is a motivator. We're all motivated by fear. And so we do have to sort of calibrate our responses so that they're appropriate and honest, and we're not trying to hide things from people or infantilize our response.
Great, thank you. I have a question here coming in from Philip in Spain. He writes, how can we best adapt participatory approaches to generating and disseminating key messages, dealing with misinformation and rumors, etc., when social distancing measures are in place? Back to you, Virginia.
Thank you. I know that Manuel from Cox's Bazar will be talking about that shortly. Rumor tracking is actually really important, and it can be done like I was referring to before with the WhatsApp messages and what have you. It can be done remotely, and it is essential for recalibrating your communication messages and your daily updates, etc. It's when people in camps, for example, in Cox's Bazar, so heavily rely on their religious and sometimes mythical understandings of why their life is like it is, and it has proven a great crutch to them. When rumours, etc., come through that prism, if you like, it's extremely hard to disrupt. But it doesn't mean that we should stop trying. When you're doing social distancing, it's a great idea if people already have those contacts in the camps with their key influencers, the leaders of women, people who are imams or trusted people who you know will be able to speak to you and speak to the community with integrity. They're the people that we should be really relying on at this point when we are in a skeleton situation or we're unable to have, as you say, those kind of mass meetings or mass disseminations and discussions with people.
Perfect. Thank you so much, Virginia. I see we have other questions, so hopefully we'll be able to come back to you later in this session. In the meantime, though, I would like to jump over to Manuel on this topic of rumor tracking. Manuel, I understand you have been using rumor tracking in Cox's Bazar. Has that helped you in the response? Over to you, Manuel.
a way that we are able to understand their fears and their needs for information. And the rumor tracking is a fundamental piece of that. So far, we have done that with smaller focus group discussions and trying to get a sample of a broader community of the refugees, and then process those focus group discussions and put out messages for sectors to understand how refugees are perceiving the crisis. Because in that process, the questions that are being raised in complaint feedback mechanisms or in these focus group discussions can then be constantly approached from an explanation point of view. We launched a system called COVID Explained, which is this recurrent assessment of how the refugees are interpreting the messages and their concerns. And we have to continue adapting our systems and our practices. Soap distribution has started door to door because people didn't feel confident or they were scared to go to distributions. Social distancing in distributions has reduced the amount of people that can have access to humanitarian assistance every day, either is a gas distribution, a soap distribution, or in a clinic. And so there are a lot of these small adjustments to operations that come from the perception and the rumor, fighting the perception and the rumors that we are gathering live from the community. I hope that within the next couple of days, with the reopening of communications in internet access, we will be able to do these through open source WhatsApp groups and be able to allow refugees to reach out through these WhatsApp groups and give their own questions, for which we as a group, a community of humanitarian actors, will be able to provide clarifications and explanations, basically on audio records, not on messages, because a lot of the people are illiterate, but being able to have refugee volunteers that record audio messages that then are massively disseminated and people can exchange among themselves in their own language to answer their own questions.
Excellent. Thanks so much for that, Manuel. I would like to turn now to the technical standards in the Sphere Handbook. So jumping back to the Sphere world here. Kit, in the Sphere chapter on WASH, what specific guidance would you highlight for the COVID-19 response? Over to you, Kit.
Thanks, Angela. I'm going to take a slightly different approach, and I'm going to look at how we're looking at responding in the sector, and that we've got two main things we want to be focusing on. The first is how we as a sector combat the spread of the disease and support the response to it. And the second is reducing further stress on already overwhelmed health services. So to go to the first of these, I think what I want to do is to go back to basics for a moment or two. So asking the question, what is WASH and why do we do it? Oh, thank you for the first slide. Can you click the first one, please? Oh, I can. Oops, a bit far. So this, for those of you who haven't got much experience in WASH, this is our F diagram, and it explains the fundamentals of why we do WASH, which is primarily to interrupt the transmission of communicable diseases. The F diagram, as you can see it, shows the main fecal-oral transmission routes of diarrheal disease. The thin arrowed lines between the green squares, which are these transmission routes, linking feces to faces, and also how we can interrupt this transmission by putting up specific barriers through the provision of safe drinking water, reliable sanitation, and good hygiene practices, which are those smaller green letters that you can see on the transmission line. They're our barriers. So the F diagram is about fecal-oral transmission of diarrheal disease, but it's pretty well applicable to any pathogen that causes diseases. And what I've done is I've created a COVID-specific diagram, which we're calling the COF diagram. Thanks to Antonio from IOM for that suggestion. And again, if we have a look at those thin green lines for transmission routes for COVID-19, WHO tells us there are two primary routes. The first through coughs and sneezes, so that's that top direct line from face to face, the respiratory transmission line, and the second through hands or surfaces through contact transmission. If we think about these modes of transmission, then our primary barriers are largely hygiene related, covering your sneezes and coughs, good hand washing practices, and cleaning high-risk surfaces in public places, in schools and other institutions. However, there are other things we can also do in our WASH programs to enhance that physical distancing at water points, at laundries, at communal or shared toilets, so that we can decrease the time people have to spend in queues. We can increase the number of water deliveries or perhaps to more and temporary water points. We can introduce spaced queues for services such as water points or distribution points. And I think the WFP and IASC guidance has been issued on that, and it should be available on the net. And here's a wee picture from WaterAid, I think in India, that came to me courtesy of Brian Reid, that shows how local communities are looking to develop those physical distancing practices at a water point. And it's a fairly busy small village, which could perhaps be also applicable to a camp. We can also make sure that people have enough household water storage containers so they can choose when they go to queue to fetch more. We can reduce the number of people touching the water points by perhaps introducing or reintroducing caretakers. And as difficult as this is, we probably need to be trying to introduce more water into the system. The W's that I'm showing up there. More water for hand washing, but also for other cleaning and laundry. One thing that we've also seen from the WHO guidance is that we need to make sure that the people collecting solid waste from households or community collection points have the right kind of personal protection, and that households are able to space out how their waste gets into that system. The big critical thing for us is that we need to make sure that settlement managers see people working to deliver WASH services as essential staff. They should not be redirected to other tasks, and they need to be protected when they're doing their job. Sorry, my bad. So I wanted to say that the 3 hygiene promotion standards in Sphere are a good place to start looking at what we can do. As Aninia, as Virginia, as other people have focused on, our community engagement teams are a good place to start with a good hand hygiene messaging and encouraging good behaviours. And at the same time, we can use them for other good behaviours and other key messaging, like health-seeking behaviour, for example, in a malaria context, in physical distancing, and destigmatisation, which I think was something that Virginia had touched on as well. In crowded conditions like camps and transit or reception centres, where social distancing and isolation is going to be difficult, I think hand hygiene becomes more important than ever, and delivering these messages, it will not be easy. We've heard from Virginia some ideas about how that can be done in this context. If we then take a look at the 5 key actions recommended in the ASC guidance on COVID-19 and camps, WASH works directly in all of them. The last piece I wanted to touch on was, and probably it's as important, and hopefully my colleague Jude from Health will also talk about this, is that as people are seeking support from local health centres, there is a standard that helps us to identify as WASH actors what we can do best, what we need to be prioritising in these healthcare settings. I think in hindsight, this standard that we developed was actually made for this kind of condition, this kind of context. And that's something that can give us some areas where we can prioritise the sorts of activities we need to be doing as WASH actors in those contexts. So that was a description of the first kind of direct actions that we can do in this response. And I think that's where many of us are already very much focused, where we're mobilising funding, where we're getting people out there, and where our donors are actually already helping us. However, it's just as critical that we make sure that we can continue to provide at least basic wash services to people in these high-risk environments. Dr. Pramandra, I'm not sure where you're from, but mentioned fecal sludge management in camp settings. It is critical that we don't let that fall over. What I and other WASH people think about a lot, wakes us up at 2 o'clock in the morning, is what happens if people become scared of shared or communal toilets or communal water sources because of COVID-19. What can we do about that? What happens to all of the women and girls in our camps who are trying to manage their menstruation when they don't have the space, the supplies, or the water because of the COVID-19 response? What do we do about a water supply service that doesn't have the necessary supplies or personnel to treat the water due to a logistic breakdown? What are we going to do about sewage services without the funds to pay for electricity because the local economies have tanked? And what are we going to do about seasonal outbreaks such as malaria ripping through an IDP camp in a place already overwhelmed by COVID-19? On top of that, as we all know, we've already got 2 billion people without access to a safe toilet. What are we going to do in this response to ensure that those people are trying to gain access? We can't stop doing what we're already doing. And if we go back to the Sphere standards, they help us to go back to the basics and to prioritize what we can be doing, what we perhaps can leave till after the response has calmed down a bit, but what we need to be doing now in our context. Thanks, Angela. Back to you.
Terrific. Thank you. Yes, we have a lot of questions coming in, Kit. Some technical questions, some broader questions as well. I'd like to try and tackle a few of those if possible. So first of all, it's from Safwatul, connecting from Bangladesh, writing, camps where water is scarce. In camps where water is scarce, frequent hand washing with soap may not be feasible. Is a 0.05% chlorine solution for hand washing adequate to kill coronavirus? Over to you, Kit.
Yeah, this is a good question, and it's something that we also tried to look into and address and had a lot of thought about for the Ebola response, where hand hygiene was equally important. One thing we know about chlorine is that it attaches to the particles on our hands that aren't necessarily the virus. It might attach first to the dirt, to the sweat, to the dead skin cells. So it won't be as effective in targeting the virus as soap will be. The other problem is that it's the rinsing action that you do to get the soap off your hands, which is part of that the process of making your hands clean. And finally, chlorine is really not a nice substance to be handling. It can damage your hands quite badly. We certainly saw that in the Ebola response as well. Our recommendation, and I think it's most of the guidance documents you'll see out there, is soap and water or hand sanitizer if you can.
Great. Thank you so much. We have also a couple of questions regarding disinfection. We have a question from Aude in France who writes, what about home disinfection for houses with suspected or confirmed cases? Is this relevant or not? Or should home demonstration sessions of disinfection of household surfaces be carried out instead, combined with the distribution of hygiene kits with disinfectant? And a related question from Petros, connecting from Greece. Standards for disinfection of office spaces, of communal spaces, and residential spaces. Any guidance on this? Could I turn back to you, Kit, for these two related questions?
Yeah, sure. If we go back to that the cost diagram, thanks to Antonio, the secondary transmission routes are definitely surfaces. So disinfection is an important thing. How you go about it, it's going to have to be a little contextual. I think Aude's suggestion of doing of teaching people how to do it themselves and giving them the supplies that they can do it is a good place to start. There is guidance from WHO about what to use for disinfection, and I'll get a link up if I can to the WHO guidance on WASH in the COVID response. in places, in relation to the second question, in places that are high risk where a lot of people go to and a lot of people do use, I think there needs to be a really concentrated effort on getting those surfaces disinfected. Again, we can go back to the WHO guidance to find some really practical advice, and I think it should be part of the SOPs for managing public spaces, which it's unavoidable. We cannot close absolutely everywhere. People will need to be seeking help and support. We've got to make sure those places are safe for them to use.
Great. Thank you so much, Kit. We'll see if we can come back to you again later. In the meantime, I would like to turn to the individuals we have who are working in camps around the world to ask, in your context, how have you approached hand washing, which is so central to the response now, especially in the context of COVID? What have you done to get information across to camp residents? Are there other WASH-related concerns that you see arising? Could I turn first to Manuel?
Hi, thank you. Well, hand washing in Bangladesh due to unavailability of water is complicated. There has been a significant increase of hand washing points in the majority of the facilities where the humanitarians perform actions, but also there has been the import of some technology like the tip taps, which use very little amount of water, and they can be chlorinated, or we can have the soap on a string, but essentially continues to try and explain people that the hand washing is vital to be performed every time they go to areas with higher concentrations of people, and if possible, during the day-to-day whenever they find a water point. But it's going to be very complicated to manage the availability of water quantity over the next few months.
Got it. Thank you. And Sibylla, how is the situation where you are when it comes to WASH in general and hand washing in specific? Over to you, Sibylla.
Yes, thank you. We have launched key messages on both banners that we spread about in several different locations in the camp, especially at water collection points where IDPs usually come often. These key messages were all based on the inputs from the WASH cluster and the health cluster, and also in line with the guidance that we got from the Ministry of Health and the Directorate of Health. In addition to this, we also set up some, with the support of UNICEF, some mobile tap stands in each mini management caravan. These caravans are usually places where IDPs can come to register complaints or provide feedback or share concerns to basically encourage people to wash their hands. And thirdly, we launched videos on on WhatsApp groups and Facebook groups in which we knew that IDPs were using. We have used a lot of, we have held some meetings with representatives, and we worked with them to ask if they could further launch campaigns in which a medical agency was explaining with video footage how to wash your hands, probably preventing the spread of the virus. Thank you very much.
Great. Thank you so much, Sibylla. And I'd like to really invite all of the participants, both in the Adobe platform, and we still have more than 800 people following the live streams. If you have experiences that you can share from the context where you're working, please do share those in the chat so we can have that as part of the discussion. It will be a very rich way for all of us to share our experience. And we can also then follow up with you on those points, on those examples after the event. So Richard, can I turn to you? Same question, having heard from kits about wash-related concerns, specifically about hand washing, but other challenges as well. What's the situation? What's been done, and how are you getting information to camp residents in your context? Over to Richard.
Thank you very much. In South Sudan, as I said in the beginning, that we are working on the preventive measures. So we are cognizant of the crowded nature of the POCs or of the camps that we're working in currently. So we've come up with some 5 key messages that to encourage the IDP to make informed decisions whether to continue to stay in the displacement location with the crowded condition. Of course, we're providing the background of the COVID, the infection method, where that's not, if you live in a congested area, then you're more exposed to spread the transmission. So we're advising them to make informed decision whether they want to stay or if they have any other place where they want to go, and how they can be supported to move where they want to go. But also we're providing information. If you say you're going to area A, we provide you with information in terms of the services that are available in that location, in terms of the partners, what they're doing there, in terms of the security. Of course, South Sudan still has ongoing security situation going on. And when you choose a place which has ongoing conflict, then you are advised maybe to reconsider where you want to go. We also have information on those who want to stay. If you choose to stay, which is primarily your choice, but then we provide the information that services will continue, but this is dependent on 2 levels. One, if there's an outbreak of COVID in the country, there could be some disruption on the services that are being provided to the displaced persons in the camp. But also the other part, if there's an outbreak in the displacement site itself, that maybe the government will declare complete lockdown, no movement of people inside the camp, and what services can still be provided. So this is meant to empower them with the information so that they make an informed decision whether to stay or to go. Apart from that, what we've done, we've coordinated with all other partners working in the displacement locations and come up with a contingency plan. The contingency plan is staggered in 3 phases. The first phase is what they are doing now in terms of preventive measures of contracting COVID, how they're dealing with the distribution, increase of the water supply into the displacement site. Then the other phase is when there is an outbreak in the country, what activities the partners in the particular site will be doing, and the activities they will do when there's an outbreak inside that POC. That's what we're doing currently. Thank you very much.
Great. Thank you very much, Richard. I'd like to turn now back to Aninia briefly. We've had a number of questions coming in regarding other potentially applicable standards. There was a question about the camp management standards, about the HSP. Could I turn over to you, Aninia, to share with us any additional points that you can do on that? Back over to you, Aninia.
Yes, thank you. Thanks very much. There are camp management standards in the making. They are indeed available in draft format, and they will. I pulled them up here. They actually, and I'll read them to you very briefly. There's 5 commitments in there, accompanied by standards, and they very much cover what we have been discussing. Commitment 1, Standard 1 talks about coverage. It talks about displaced populations have access to the services that the site management agency provides, which very much also links to the Sphere Protection Principle 2, access. Commitment 2 is about representation. Site governance and site committees are representative of and accountable to the displaced population. Commitment 3 says services provided through a network of site-level agencies meet the needs of the displaced and host populations. Commitment 4 talks about the site environment which is safe and physically, socially, and culturally appropriate for inhabitants, very important. And then Commitment 5 talks about site closure and exit planning, keeping the safety and dignity of people in mind. And these coordination standards complement very much the standards that are in the Humanitarian Standards Partnership, that is Sphere and 6 other handbooks that cover humanitarian sectors. Those are in particular child protection, education, livestock and livelihoods, economic recovery, and market analysis, cash-based programming. And we are hoping eventually to welcome the camp management standards into that Humanitarian Standards Partnership, and that will reinforce these messages throughout, because we all cross-reference each other and enforce each other, hopefully. So thank you. Over.
That's perfect. Thank you so much, Aninia. I'd also like to jump over quickly to Sibylla. Could you come in just very briefly on that issue of key messages and combating rumors that came up previously? I think you have some input on this. Over to you, Sibylla.
Yes, thank you, definitely. So yeah, exactly what was mentioned. In order to fight the disease, we need people to adhere to the guidelines and preventive measures that they can take themselves. This can only be done, of course, if the community is informed and understands the matter. So what we did in our camp is we asked the camp assistants or community mobilizers to keep walking around the blocks, basically to identify any rumors. And we also launched very quickly the key messages with the WASH and health clusters in order to ensure simple and accurate information sharing, and ensure also that it's all coherent to avoid any rumors. We actually try to also dispel some of some rumors that we had heard before through our key messages, such as dispelling the myth that putting chlorine on your skin will not protect you from catching the virus and can actually be dangerous, as was mentioned before by our colleagues. And IDPs came up to us and thanked us with the flyers, because for them they see any information coming from camp management as an official source of information, rather than the information that they have that could sometimes be false information through social media. And it's very interesting because actually we witnessed a change of stance of the camp residents based on a couple of weeks before, when the first cases just were confirmed in Iraq. We received the recommendations of the directors of health to restrict movement in and out of camp as a response to the outbreak. And at first, we saw the camp residents were quite furious about the restriction of their movement, but after a while, after we launched the campaign and we of course worked a lot through the camp representative structures as well, women and youth committees and sector leaders, we witnessed actually a change of stance, and we actually witnessed several people asking us to have even stricter measures because they started to understand the severity of the matter. So I completely agree. Information sharing is crucial. Thank you.
Thank you so much. That's very interesting and very encouraging, Sibylla. So thank you so much for sharing. I'd like to turn now to another key technical area covered by the Sphere Handbook, and of course, very centrally relevant in the discussion we're having today, that is health. And turning to Jude, from the health chapter, what guidance would you highlight for the COVID-19 response? Over to you, Jude.
Hi, good morning, everyone. So I am going to avoid duplicating what Kit and Aninya have also spoken about, but then concentrate on three main areas that seem most relevant and seem to be could potentially have the greatest impact on our sources of concern. So the first will be looking at the systems and structures. The second would be looking at education and messaging, a few more specific areas, and then something looking at safe and dignified management of the dead. So the first point really is that everyone will really need to be looking after healthcare workers, whether that's doctors or nurses or community workers or incentive workers. Throughout this, especially with more and more remote working, they're going to become increasingly vulnerable, not just in terms of being exposed to the infection, but also from huge amounts of anxiety and concern from within the communities. They're going to be asked questions, they're going to be put under pressure in very personally and professionally stressful situations. There are many ways that this can be done, and again, it will be very, very context specific. So, next, just to talk about structures. So this is looking at healthcare structures. Again, this is going to be very, very different depending on the context. And there's a lot of discussion at all levels about cohorting. So either this is separating out confirmed cases from suspect cases from those with no symptoms, or more realistically, separating out suspect cases where there's no way to confirm them from people that are asymptomatic. Whether this can be done from within the same health facility, whether the creation of a tent is possible, or if you do have two health facilities near each other, have them completely separate. One concern obviously is that if you have a large cohort bay that then gets very full, are you increasing risk? Something that has worked well within some settings is actually having separate entrances. And the obvious case for these would be for maternity care. What you don't want is having pregnant women who need to continue to seek care, sharing entrances with people who are potentially infected. Another issue that's already been brought up a couple of times is the issue of crowding. Prioritize your services. Realistically, not all non-urgent healthcare can continue. Potentially something that can be done is having a different area of the camp have access to services each day, or under fives, or saying, look, we will prioritize older people. I think that's something that would need to be looked at in each individual circumstances. Moving on to systems, triage is going to be really, really, really important. So whether this is triage of symptomatic cases from asymptomatic cases, that's one thing, but also emergency care from non-emergency care. It all comes again down to the prioritization. The infection prevention and control, Kit has already discussed this within the context of health facilities. It's very much going back to best practice, and this is in the Sphere standards, but also WHO has created some new COVID-specific documents. But again, it comes back down to basics of best practice. Washing your hands. This is for everyone, but healthcare workers within facilities and patients within facilities. PPE, I will come back to this in just a moment, because this is again a huge source of anxiety and a huge worry about availability or lack of availability. And the other issue is finding a way to continue your basic services. Immunization has to continue. Different ways of working out how to do this. to ensure social distancing, to avoid large crowds. Again, this will be very context specific. HIV and TB, whether it's possible to manage these programs remotely, which can be done in some contexts. Some suggestions, some people have said it's been possible to give a longer duration of medications. However, supply chain, again, that might not be possible. But yeah, working out a way, again, to make sure those continue. And similarly, maternity services, as mentioned before. So just going on to the next slide. So, as has been mentioned multiple times already, the issue there are huge issues related to misinformation, and most relevant to health, really, obviously, is to do with infection prevention, but also potential cures. We've heard lots of damaging stories about of people using alternative medications, but also some very negative coping strategies to start to pay for medical care when there is essentially no treatment at this stage for COVID. Clear, simple messages about the use of facilities. I noted someone had mentioned earlier on that actually people were very worried about coming to facilities, seeing staff in PPE. So I think it's really worth making it clear when discussing with the communities why they're in PPE, and it's for everyone's protection. Another relevant chapter that is related to COVID is the relevant standard is the palliative care standard. This is something that goes from healthcare personnel to people communicating within the communities, whether that's volunteers or religious leaders, but just the understanding that this is going to be there are going to be people who are going to need to be palliated. And then education and messages about burial for those who die at home. Realistically, unless you have very expansive healthcare facilities, most people are going to be dying at home. So just making the processes clear, honest, and safe about how that should be managed. And on to the next slide. So this is a very, very brief summary on safe and respectful management of the deceased. This is based on the most recent WHO guidance, but I think something that's very important to say is that lots of countries have their own guidance, but that deviation, especially when it comes to whether bodies can be buried. WHO said that this is safe, but other countries have said that it's not. Again, there are lots of beliefs, religious and traditional, around this that need to be discussed and communicated. So the first point when it comes to respectful management of the deceased is, at this stage, have honest conversations with community leaders, religious leaders, and the community to create a plan to find an area where people can be buried, to look at transport of the deceased, to look at who's going to do it. The last thing that anyone would want is for this to be rushed and more distressing, and then for infection control also then to be an issue. Again, community awareness, transparent conversations. There will be a point, I'm sure, where it will be necessary to stop visitors coming to health facilities to see family members. It might then be a situation where you have people dying in health facilities who can't be identified. So just really working out how to make sure that people are identifiable. And then education of traditional burial attendants. Again, there's actually some very WHO guidance on management of the dead in in resource poor settings where traditional burial attendants will be used. The key messages are, and this comes back to the fact that the virus lives on the surface, any surface, and that includes the body surface, but also it's transmitted by aerosols. So avoid unnecessary touching of the body. So this is healthcare workers, family, burial attendants, and especially at funerals, any kissing and touching of the body should be avoided where possible. Again, this is going to be a very honest conversation with the community. Wrapping the body in cloth and covering the mouth should reduce the risk of infection because you've lost that surface. There is no need to use body bags based on WHO guidance, and I know they can often not be available. So again, this is back to the PPE for traditional birth attendants. So gloves need to be worn and masks if possible. Again, I know that supplies are going to be short, so washing the clothes that they're wearing immediately, and this is coming back to the chlorine, and that's a kind of minimum standard for the clothes that the traditional burial attendants wear. Similarly, the clothes of the deceased would need to be washed in a similar way. I know there was discussion early on about, keeping washing surfaces within the household, and that's what that comes back to. That's what that comes back to as well. And then again, local guidance, if it exists, that can be about burial and cremation. Just one other point, that I've seen that's come up is about people using gloves and masks and then being distributed in kits to families. The main issue with distribution of gloves is that the gloves themselves would need to be washed as you would wash hands. So actually, hand washing is adequate. The problem is, if people are wearing gloves, they feel sort of falsely protected. This isn't healthcare workers. This is people who aren't working in healthcare, that they feel falsely protected, therefore don't wash their hands. So that actually would increase the transmission. Similarly with masks, that actually the guidance is that unless you're caring for someone with COVID or you yourself are symptomatic, the use of masks isn't recommended at this point.
Great. Thank you so much, Jude. We have a lot of questions that have come in here. I'm going to bring up just a few of them, and then we're going to move on to hear again from our colleagues in different camp contexts around the world. But first of all, this is it's an essential question, although a basic one. Could you please clarify the ways in which the coronavirus spreads? So that was a question from Ahmad in Nigeria, but I've also seen in the chat and in the Q&A, people are wondering, is it to be considered an airborne disease? Someone said he heard that the coronavirus was detected in wastewater, so he's wondering if that's a transmission issue. Could you briefly clarify how it spreads? Over to you.
Okay, so yes, it's an airborne aerosol disease. So just to go over a few things, that the 2-meter transmission radius is what is given as the radius for when there is aerosol generated. So that is certain medical procedures. The 1 meter radius will be normal contact, normal breathing. So there we go. So there's 2 different radiuses there. So that is airborne. Something that's important is that between 10 and 20% of patients do present with, while there is limited evidence that it can be, there's no fecal oral transmission evidence. Obviously, we're still at the very early stages of learning about this. So good infection prevention control that you would normally use for diarrhea would need to be followed. It's surfaces, so it's when you have an aerosol generated, it's surfaces that are the issue. So 2 to 3 days, it probably lives on surfaces, 20 hours on cardboard, and it says between 2 to 4 hours on paper. So it's there, it's touching things. It's touching an object and touching your face. So that's where washing really, really comes in. So whenever you touch anything, that it's that risk of transmission comes.
Great. Thank you so much, Jude. I understand from Sibila that there's been a question coming up in her context. Sibila, can I turn to you to hear more about that?
Yes. Thank you very much. Yes. I was wondering, can the virus be transmitted by stool? We are concerned about the latrines that people share in our camp. Thank you.
So yeah, this is something that I think that Kit can also answer, that there is no evidence of it being transmitted by stool. However, but that obviously there's still a lot to be learned. But any stool management, so shared latrines, everything should be, the best practice should be used. I know that doesn't give an absolute answer, but yeah, good waste management is what's needed to continue.
Great. Thanks, Jude. Could I turn to Kit to come in on that as well?
Yeah, absolutely. There's an excellent guidance note that came out of WHO and UNICEF. We'll definitely share the link to it, and if you search, the search topic should be WHO WASH COVID-19. It'll be in the top 3, whatever results come back. There's a bit of research that's been pulled together looking at the persistence of COVID-19 virus in drinking water, feces and sewage, and on surfaces. There are risks, absolutely, but they are low. On surfaces, they're higher because of the way the virus transmits. If we go back to the diagram that I presented, that little cut down F diagram, the cost diagram, that shows the main transmission routes, and it shows the main barriers as well. They're the things we need to be focusing on. Over.
Okay, great. Thank you for that. Back to you, Jude. A quick one here. We have questions from Sarah in Iraq and also Pauline in Kenya asking something similar. They're wondering if chloroquine, hydroxychloroquine, and azithromycin are working in treating COVID-19 and whether or not those can be used as preventive drugs. Over to you, Jude.
So it's a very, very good question. At this point, there isn't evidence that they are effective in treatment or prevention. That isn't to say that some countries aren't using them. That the only prevention at this point is, social isolation where possible, and good infection control and hand washing. It might be that guidance changes, but at this stage, in very difficult settings, it wouldn't be where there is recommendations to channel effort.
Excellent. Thank you so much for that. So now, as mentioned, I'd like to turn back again, if I can, to Manuel, Sibila, Richard, to hear about the situations in your context when it comes to the issues and the guidance that we've heard coming from Jude on the health questions. How are the health concerns being expressed in your context? Have you had to look at retraining staff or reassigning roles in the face of emerging health needs? And how are liaisons with the ministries of health working in terms of data collection, testing? Anything you can share with us from the context where you are. First to Manuel, over to you.
Thank you, Ingrid. I think that once more on this, we would go back for the extreme importance of camp management to contribute to the coordination and the support of the intersection of the different areas of work that are needed. WASH and health and site management and shelter, we need to work more together to make it more effective. In terms of health, I think the first thing that has been happening is, at least in Bangladesh, the reanalysis of the structure of the teams to be able to be ready to provide isolation to people that test positive, and trying to understand how testing can be done, knowing that it takes time, is difficult, and will not be available in large scale for what we for now know. And so this repurposing on teams, and I also think that the staff in Bangladesh at large has been extraordinary in making themselves available to be repurposed to be part of the restructuring of the health teams in all functions, from the cleaners to the caregivers to the medical staff in itself. And I think it's that solidarity that is very, very important.
Thanks so much, Manuel. Sibylla, could I turn to you?
Yes, thank you very much, definitely. So you had three parts of the question. I'll start with the training of our staff. Yes, we retrained them. We actually had, once the first case was confirmed of COVID in Iraq, the health cluster immediately provided a training, and to all of camp managers and camp management agencies. We then shared this training with our staff. We trained their staff, and we shared many material that was made available through WHO. And then on your question on health concerns, how they're being expressed. So our health partner runs a health clinic in camp, and normally camp residents do not have issues expressing their general health concerns. Of course, it's a bit different when it concerns sexual health concerns. However, in the past week, in this current context, we have witnessed that people with high temperature are hesitant to go to doctors. They rather wait for a few days before going because they feel it's just a flu. I will wait it out, fearing that if they will proceed to the clinic in camp, they might immediately be referred to the hospital and be placed in quarantine for the upcoming 14 days. This is a bit problematic, and we keep also stressing to camp residents and partners to refer any person that is showing fever symptoms to the health clinic, especially given the advice of the Ministry of Health that the earlier the virus is detected, the better. But on another note, concerning to ask for vaccinations against COVID-19, and the health partner took it as an opportunity to actually re-advocate on vaccinations in general, and has vaccinated many children that were previously no-shows. You were asking also about the data collection. Our health actors in constant coordination with the Directorate of Health and the Ministry of Health. Whenever there is a suspected case in camp, this luckily happened only once, and was within 3 days was confirmed negative. But when this happened, they immediately refer the case to the hospital for testing, and they inform us, and we inform the CCCM cluster. It was mentioned here before as well that coordination is very important. We are in constant coordination with our health partner and also with our WASH partners, especially in this context. We set up a tent or an isolation space for our health partner on their medical terrain, so that they have the space to be able to isolate a suspected case, should they suspect a case, for the time being that the referral is made to the hospital. So once the referral is made, a special designated ambulance that was given by WHO to the Directorate of Health would come to pick up the suspected patient, and for the time being, this patient is isolated in a separate space inside the clinic. And lastly, we are currently working on identifying perhaps a site located near to the camp in which we can support our health partners should we request more, should we see the need for more isolation spaces. And they have informed us that should we create isolation spaces, it's very important that each individual would receive his or her own tent. Thank you.
Thank you, Sibila. And Richard, could I turn to you with the same questions regarding the health issues and guidelines related to the COVID-19 response in your context in South Sudan? Over to you, Richard.
Thank you very much. As I mentioned in the beginning, that South Sudan, as of today, we don't have any known case, but a lot of preparation work has already been done, led by the Ministry of Health. The CCCM cluster were linked to the task force that has been set through our technical working group. We've set a technical working group of communication and community engagement that is linked with the task force, because the task force also came up with a response plan. And one of the pillars of the response plan is communication and community engagement. And that falls under our umbrella through our technical working group. So we've been working closely, even the message that I talked about earlier on, working closely with the ministry, working closely with everyone else to develop these key messages that we are going to share with the IDP population. But also, the other context that I needed to have brought clear is that much as we don't have any case that has been identified, the health system in the country is broken. The government has set up an isolation unit in one of the hospitals in Juba here. We are told it is a 20-bed hospital and 5 ventilators. We don't know how many test kits are available. So it's really going to be difficult if we don't continue with these preventive measures that we are doing. Now, there are part of the capacity building of the staff. I talked about the contingency plan. We are now doing a tabletop exercise in all the POCs. Here in South Sudan, we call POC protection of civilian sites. This will be a new term to other people who are listening to me online. The camps are in the base of the peacekeeping force. So we call them protection of civilian sites, POC. So we are doing now a tabletop exercise, running the worst case scenario when there's an outbreak in the site and what we need to do. So the partners that are involved have identified the IDPs themselves, who will, if we're not able to access the site, who will eventually be able to provide some services. So training is ongoing. We identified a number of key gaps in the tabletop exercise. Now we've engaged the partners that are doing the training, setting up those who have not done the recruitment of the IDPs themselves to set them ready and keep building their capacity to be able to respond. Yeah, I think that is all now from here. Yes, about the isolation unit, we have identified in every POC, I hope I'm comfortable now to use the term POC, in every POC we have identified isolation site. No construction has taken place as yet because we still at the stage of not sure what really to do at the site at the moment. Apart from that, camp management is working with the peacekeeping force and reinforcing the entry, because the POC is quite barricaded with the fences. So the entry and exit of the POC, we have set up the hand washing points. We're taking temperature of those who are coming in. Every time, whenever you come in, you have to wash your hand, your temperature is taken. So that is what we're doing at the moment in South Sudan. Thank you.
Thank you, Richard. Now I'd like to turn to Dare to see if he can say a few words on key points to consider in relation to the standards, but looking at remote management scenarios. Over to you, Dare.
Thank you. I hope that you are hearing me loud. Well, I would like to highlight that now we are dealing with a situation that has a multi-layer of complexity. Do you copy? Hello? Yes.
Yes, we hear you very well. Go right ahead.
Thank you. So one is the particularity of the camp and camp-like setups, which makes them highly vulnerable against COVID-19. And the second, which is also important, is that we are going to potentially experience a remote management situation. And here we need to consider some key measures to take into consideration. One of them is considering to relocate and to decongest the camps prior to the situation. And here it is very important for us to keep a very strong messaging with the communities both in and out of camps that these actions are taken as preventive actions, not as a response to avoid any kind of increased concern and chaos in the area. The other thing is to identify the weaknesses and the risk areas in many of the camps where we are operating in. As an example, some of the camps have higher rates of elders, and some reception centers are much more exposed to risks. It is also important for us to identify some of the key actors that might be still able to reach these camps in case we experience remote management context. Key medical NGOs, MSF in my case is one, and of course the Red Crescent movements and the Red Cross and the civil defense of these actors have been able to reach when the situations have been very much more difficult. It is also important to start already putting some measures in place, which I also think that some colleagues have mentioned. These measures could be delivering the items directly to the IDPs in the tents and in their residences without promoting a mass gathering where we find it very difficult for us to manage and to keep the social distance. Predefining referral pathways to the hospitals and to the reachable medical facilities is important. And again, the communication with communities, both IDPs and the host communities on the scenario of having a remote management to keep them abreast that we might not be able to reach them as per the classical situation if there is a kind of lock-in situation. So to keep them informed that if the situation gets more deteriorated, this scenario is a scenario that they must be aware of. Now, in this situation, the do no harm is an important principle to consider. So also the staff of the organization, normally our members are more anxious to continue providing services. In case any of them is affected and infected, it is important to alert that their presence could represent harm to the site and to the IDPs themselves, and to reduce the movements to the extent possible already between the sites, if this is possible. Most importantly, in these circumstances and out of our experiences in a few countries, I would like to highlight that there will be many communications online and by email and by the phone. It is important to always remember the data privacy when you mention the names of the infected people and the names of the sites. We always have to take into consideration the security and the data privacy issue. Just to conclude on my input, I would like to highlight that the camp management standards have been challenged against the remote management situation by the global CCCM cluster. There are some documents available and experiences that could be shared by the global clusters on how to apply the camp management in the remote management context. Our colleague Jennifer Kiembo is dialed in and listening to us, and also the other global cluster teams now are taking notes. So please always feel free to reach to us should you need advice on providing response in remote management context. Over from my side.
Perfect. Thanks so much for that offer, Dare. Very much appreciated. I'd like to jump over now to Kit quickly. We've had a number of questions coming in asking about specific numbers. Can we find specific numbers in Sphere, in the other relevant standards, when it comes to the amount of water, soap? There are other very specific questions coming. Would you like to jump in perhaps with some thoughts about again, how we can use the relevant standards when thinking about COVID-19 response in these different areas? Over to you, Kit.
Yeah, I would be delighted to jump in. Okay, so I think there's two key words when we're talking about the standards: context and coordination. I'll pick two standards from the book. I've got it sitting in front of me. The Hygiene Promotion Standard 1.2 about the identification, access to, and use of hygiene items. The appropriate items to support hygiene, health, dignity, and well-being are available and used by the affected people. I'll pick the second one is water quantity. That people have equitable and affordable access to sufficient quantity of safe water to meet their drinking and domestic needs. Those standards are a qualitative expression of our intent to deliver a minimum package to people. The numbers come in guidance, but the numbers are also very much contextualized. What is appropriate, adequate, sustainable, locally accepted in one context will not necessarily be in another. In places where you have a WASH cluster, or any cluster really, the standards are contextualized. You'll find them in the SOPs for the different clusters. In places where they are not, you'll need to go to a local government, probably a health official, a Ministry of Health, and find out what are you going to do in this context? What is going to be your minimum standard that you are going to reach? And the way that they get applied is to come back to that barrier diagram, the transmission routes, and what barriers are you going to put in place in order to break the transmission? What do you need in order to break the transmission? How much soap are you going to have to get out there in order to break the transmission? How often are you going to have to get it delivered to people? What kind of messaging are you going to have to get out to people and talk to people and engage with people in order to break the transmission? That's always comes back to breaking the transmission. As I said, context and coordination. Over.
Great, thank you for that, Kit. Just a quick note for everyone, as you can see, we're going slightly over time here. We just have so many questions coming in. Thankfully, our panelists are available for a few more minutes, so we're taking some liberties with the time. If you're not able to stay with us in the event, you can certainly come back to enjoy the recording afterwards. So we will be going over just a few minutes here so that we can address a couple more critical issues. I'd like to jump back now to Jude with some follow-up questions regarding health guidelines and health systems and response. First, there was a question from Anna, who wrote, in Europe, people are being told not to go to health facilities if they only display mild symptoms. Shouldn't this similarly be the case among people in camps to help reduce spread? So there's a question about advice for people with mild symptoms. Should they be advised to go to health facilities or not? And is the comparison between advice that we're hearing in Europe and then advice that's being shared with people living in camps. I'd also like to pose to you, there's a question coming in from a few people, so in Bangladesh, Mali, Somalia, asking about how to approach a situation when there is no option available for testing, and how you deal in particular with community expectations regarding the possibility for testing. So if there are different maybe health guidelines that you would have in a context when there is no option available for testing for COVID-19. And then finally, this is a related question, but also in situations with less well-equipped health systems, especially we've heard about a lack of ventilators and other important equipment for treating severe cases. Is there guidance available for health workers and others in such situations with the really dire lack of essential equipment? Over to you, Jude.
Okay, thank you. So yeah, first of all, with reference to the stay-at-home advice. Now, this again is going to be very context specific. If you are, if a Ministry of Health is saying that people have to present to a health facility, even within a refugee camp, then that is their guidance. However, you also need to bear in mind that very quickly the health facilities will get full and may themselves become an infection risk. So realistically, if you have full, small, overcrowded health facilities that serve multiple purposes, then it is much more sensible for people to stay at home and limit the number of people that they're in contact with. So, of course, multiple people sharing rooms. However, if possible, just have one person caring for them at home and keep that contact to a minimum number of people. So pragmatically, realistically, yes, mild symptoms, better to stay at home. However, if you're very confident that you can have a good isolation facility that has large capacities, then obviously the advice would be different. I think something then that comes down to good communication with the communities, that it's not that people are refusing to treat them, it's just that there isn't a treatment especially for mild cases. I will just then sort of move on to the third question about ventilators. Yeah, the supply of ventilators in most countries is going to be minimal. Potentially more relevantly, the supply of people who can use the ventilators safely, keep the ventilators clean, is also a huge issue. So even with huge numbers of ventilators being delivered to certain contexts, it's just not going to help. The treatment then comes down to supportive care, and that at this stage is known to be oxygen, again, where you have it. This will be a matter of prioritization. The amount of oxygen that's needed for some patients is huge amounts, and almost everywhere will be dependent on cylinders. So again, that's just not a viable option. And then it comes to keeping people comfortable, and as I discussed before a bit, the palliation, keeping people comfortable, managing their symptoms wherever possible. I know many clinics will have nebulizers. The WHO guidance classes these as aerosol generating procedures. So that's the increased risk to people around them. If you don't have the adequate PPE, then you really need to think about whether it's safe to use the nebulizers, and that's obviously something that the medical teams will discuss in more detail with you, and then to be able to communicate to people. The options where there isn't any available testing, which again is probably the majority of contexts at the moment, that there are, and I will post some links. There are case definitions that are being used. They're good. They vary in sensitivity as to how many cases that they pick up. Realistically, they are probably picking up more cases than are actually there, because don't forget that the pneumonias will continue. All your other illnesses that give you a high temperature, Kit mentioned earlier, malaria, that gives you a high temperature. All of your other dengue fever, that gives you a high temperature. So that having that as a case definition, you might end up with more cases. So it will just require a kind of constant review by healthcare personnel, by ministries of health, as to whether these are COVID, whether there's another outbreak going on. And yet communicating that honestly to the communities is I think is very difficult. But yeah, the testing hopefully will become more available and will actually be much easier than it is at the moment, but that is going to take time.
Okay, thank you so much, Jude. And I know you have you must have very limited time, but we may try to follow up with you with a few more critical questions, but after the event, as we're already over time. So I would like to touch on how COVID-19 leads to questions related to crowdedness and shelter. This has been a major theme of the questions coming in, also in the chat. We have participants working in camps in different response contexts, but all have concerns about the crowded nature of those camps and how that affects the possibility of social distancing, and are also wondering if decongestion should be a priority. I saw someone asking, it's all very well and good to be focusing on hand washing, but shouldn't we also have as a top priority decongestion or social distancing? Manuel, could I come to you first? What are the relevant standards that we should be looking at here, and how are you approaching questions of crowdedness and social distancing in Cox's Bazar? Over to you, Manuel.
Thank you. Well,
sorry, just a moment. Okay. Yes, we have you now on the line. You can go ahead, Manuel.
I was saying that we have, through the Sphere standards, always target 3.5 square meters per person. And I think we all also know that across the world, there are few cases where we, for context specificities, are able to meet that, which brings the situation of decongestion to the top of the agenda, especially in a situation of an outbreak, a health outbreak. In Bangladesh, it's a very, very complex situation because the overcrowdedness is very significant. The average space, it's 10, 12 square meters per family of 4.2, the average. It doesn't apply to all the families, which has deemed a stronger effort on all the complementary measures. We cannot decrowd the camps. We have to increase awareness. We have to increase disinfection. You will see on the slides a few pictures of activities being done. Again, across the lines that all the other participants have indicated. More awareness and more communication with individuals, changing the modalities of assistance from door to door with distance and precautions, but also social distancing and avoiding large crowds, improving water facilities and structuring access to health and health support. And we will eventually end with also specific isolation areas, because there will be no possibility for the majority of the families, if they have an individual with a more significant infection or symptoms, to be at home. He will need to be isolated. The individuals who are not going to be able to share with the patient with severe symptoms at the 10 square meters for 4 persons. So it's going to be a very complicated, the different sectors, health, wash, site management, shelter, are trying to understand how best to address that. But effectively, if we look at these, we would go back to the fact that well-planned settlements, following as much as possible the Sphere standards that are not crowded, have the potential to mitigate outbreaks. A lot of us, unfortunately, work against that situation because we are presented operations where we cannot afford that. But that's when advocacy enters, and we have to continue fighting for the application of the standards, fighting for the improvement of the living conditions of IDPs and refugees. Thank you.
Thank you, Manuel. Sibylla, turning to you now, we have some questions coming in from Zora in Pakistan, from Vincent in Kar, from Samuel in Nigeria, and Shehroz in Bangladesh, wondering how do you handle separating those who either have or are at risk of contracting COVID-19 from others, especially when self-isolation is clearly not an option in camp settings. Sibylla, any thoughts on that? Over to you.
So we have identified with the health actor the persons that are at higher risk of getting the virus, and the health actor is following up on these cases on a regular basis. Until now, we've dealt only with suspected cases. There are no confirmed. There has not been any confirmed COVID case in camp, and the only thing, unfortunately, we can do for the moment is to increase awareness and really ensure that the camp residents adhere to the principle of social distancing while we're trying to assess the possibility of creating another site where we could isolate possibly people at high risk or for example, new arrivals that will be coming to the camp. What's interesting as well that we've heard the muazzin, so the person that's appointed at a mosque to call a prayer, now is adding the sentence to pray at home, so hinting to not come to the mosque. So we try to encourage these kind of initiatives in camp as well, to really stress upon people that they can. It is difficult in crowded camps, but through adopting personal behavior, we try to change a little bit the spread of the virus. Thank you.
Right. Thanks, Sibylla. And Richard, from your side, anything to add from the South Sudan context?
Yes, thank you. In the South Sudan context, I think as Emmanuel has put it, it's very difficult to meet the minimum standard in terms of the living space. Most of the camps here are awfully overcrowded. But what we're doing through the Solutions Working Group, they have opened up a protection desk, and those who want to be supported to move out of the POCs, we are fast tracking that, and they're being supported good enough. The peacekeeping mission has offered the air equipment to airlift those who want to move. In that way, we'll maybe reduce the congestion in the POC. But again, the context is quite complex. While other places they're returning to normalcy, there's peace returning, other places there's conflict going on. In Marrakal, while we're thinking of decongesting the site, just on Monday, over 120 people entered the POC. So you can see what we have to deal with. Yeah, we're now talking about expanding the camp, but that's also another difficult thing that we shall do, because we had a contingency site. In every site, there's a contingency site that had planned to take in if there would be some influx in the POC. But then these contingency sites, we're turning them into isolation units. But then we're seeing some sites have increase of IDPs. We might just have to put their family tents in those areas. So the practice of social distancing, the government has banned religious meetings. There are no prayers. People should pray at home. Social gathering, that marriages or weddings, has been banned, so you need to do that at home, just to reduce the person-to-person contact. Thank you.
Thank you, Richard. Now, as we are over time now, I do want to, however, go once more around this virtual room and ask each of our speakers today if they have some very brief final point to share with us, a really important takeaway, or perhaps a greatest concern or a greatest hope for the immediate future. I'll go first to Aninia. Could I turn to you, please, for final comment?
Yes, thank you very much. Basically, I've learned a lot today, and I see a lot that will somehow go into the next handbook. Especially what I'm picking up is the social distancing element, crowdedness, remote programming, very big theme, and the further strengthening of intersectoriality. And I'm also happy to work further with the camp management standards, which help us move into that direction quite well. Thank you. And thanks for having me. It was really great.
Thanks, Aninia. It was terrific to have you as well. Kit, could I turn to you for a final comment?
Yeah, I mirror Aninia's thoughts on thanks for being involved. And for me, I think the key is that there's so much thirst for information out there. The comments from questions from people will really push that home to me in a big way. I would say there's 3 take-home things for me. One, take a look at those barriers that we as WASH people need to be putting in place to stop the transmission. 2, to put that into your context, figure out how it's going to work where you are. And 3rd, coordinate with other people. That's it. Over.
Terrific. Thanks a lot, Kit. And Jude, over to you.
Well, yes, also from me, thank you. Thank you for letting me be involved. I have also learned a lot. Yeah, I mean, obviously, like as Kit has said, those messages are massive because of this, the need to break this transmission. I think another thing to say is wherever possible, really working with ministries of health, because this is going to have to be a huge effort. It's an international effort. So keep up all those communications with them, and similarly the communication with your communities to get buy-in on everything that you're doing in your very specific context. But yeah, and I think the sharing of experience, if that can just carry on however it can be done, I think that's hugely important.
Terrific. Thank you so much. And could I turn to Antonio for a comment? I know you were very active in the course of the event and behind the scenes as well with your colleagues, but love to have you come on the air for your thoughts at this point. Over to you, Antonio.
Okay, thank you very much for this opportunity. It has been a great pleasure to try to contribute to this. I just want to say a final word is that while we address COVID-19 with our WASH responses, we should not overlook other components of the comprehensive WASH response that will allow us to avoid comorbidity and at the same time alleviate the stresses on our health services in camps. Thank you.
Thank you, Antonio. And Sibilla, connecting from Iraq, could I turn to you, please, for your final comments today?
Yes, thank you. Thank you very much. Thank you for organizing this important webinar. As a final comment, I would say key is information and coordination, really. We have, at the beginning of the crisis, we received many offers to, for example, of a wash hygiene kit. It's important to really identify the need in your camp so that offers like these would better be invested in other camps, for example, that would need it more, if the need, of course, obviously is okay inside the area of your responsibility. Coordination with the competent authorities as well as I think really this crisis needs an integrated or holistic response, and coordination is crucial for that. And then communication with communities, keep them informed, try to be ahead of rumors, ensure people understand the severity of the matter, but do not create panic. and speak to professionals, consult guidelines, see how you can implement them best in your context. For example, also about distribution, think about how you could change practices inside your own context. Thank you very much.
Great, thank you, Sibylla. Thanks for being with us. Richard, I'd like to turn to you for your final thoughts to share with everyone.
Yeah, thank you very much. To me, it has been a great pleasure to interface with this community of practice. People are looking at standard, looking at the welfare of people who have been displaced and they're not living in their own homes. And my takeaway from this discussion, again, and just need to emphasize what my colleagues have already said about coordination and the participation of the affected population. I've seen it working here in South Sudan, where the IDPs are taking the responsibility, ensuring that there's hand washing everywhere. The hygiene of the displacement site that miraculously improved within just 1 week because communication has empowered them and they've owned up the process. Thank you very much.
Thank you, Richard. And Virginia, I'd like to turn to you next for your final thoughts.
Evident that it's going to be very difficult for us to adhere to very strict standards of what is appropriate physical distancing, etc., in the complexities of the camps that we run. Because there are so many different complexities that we've heard tonight. So I think what is really important that we always keep in mind the context that we're working in, make sure that as camp managers that we coordinate, say it once, say it 3 times, but also the last thing I want to say is that it's always really important to work with the response. We're there to help them, assist them, serve them, and so we need to assist them with the most and the best possible information that we can give them in order for them to make the best decisions for themselves, their families, and their communities.
Thank you, Virginia. Thanks so much for joining us today. And over to you, Dare, for your final thoughts to share with the participants.
Well, this event was blessed with many questions, and we acknowledge that we did not have the time to answer all of these questions. I continue encouraging the colleagues to exchange amongst themselves, and they keep referring the questions to the global cluster in case of any unanswered ones. And what is most important is to try to operationalize the existing standards in a way it fits your context, and always challenge how the situation might deteriorate into a remote management context, which is the worst and the most unfortunate. I also cannot emphasize, colleagues have already mentioned, on the importance of coordination and the keeping reminding that the CCCM cluster is a cross-cutting cluster, so any question is valid. Thank you, Angad, and the other colleagues again, once and final, for the good steering and navigating of the event. Over from my side. Thank you.
Thank you, Dare. Really appreciate your inputs. And then last but not least, Manuel in Bangkok, turning to you for your final thoughts for the day. Over to you.
Thank you. Thank you to you, to all the persons that listen, and to all of us that participated. There is very little for me to say, but I wanted to stress out that many of us are working on a crisis today, on the top of a crisis that already existed. We collectively will be tested beyond our plans, beyond our capacities, but we are also the intermediaries of the concerns, the fears, and the hopes of many millions of people around the world. And we need to stand strong and united to provide that service to those individuals and listen to them and make them part of our efforts, and of course coordinate with all the possible actors, because this crisis has dimensions that we still don't know, and we need to continue in learning. Thank you so much, and keep the fight.
Thank you, Manuel, and thank you to all of our speakers today. It was tremendous to have you all on the line. I'm so glad we were able to connect with all of you. I'd also like to give a little shout out to our captioner, Pat, for overcoming the technical difficulties. It's been really helpful to have the captioning. So thanks so much for for keeping up the fight on your end as well to ensure the accessibility of this discussion for everyone. Speaking of which, we have been making a recording of the complete event, both in video format and in audio only format. So that will be available in podcast form, the audio format, and then we'll also have the full video recording available in the coming days. That will be on the event page. You'll receive an email alerting you to when those are available for you. You can also share them, of course, with colleagues. The CCCM Cluster will be organizing a series on COVID-19 and camp management. The next event on the 7th of April will be on community engagement, participation, and the response to COVID-19. You can click on the link there to register, and it will be followed by events on capacity building and remote management, adapting community center activities, digital communication with communities, and engaging with state and non-state actors in remote management. You can find information about these events on cccmcluster.org/events. I'd also like to invite you to join PHAP and NRC on the 16th of April for a webinar in which we will be discussing lessons learned regarding access and protection in restricted operational contexts and how they can be applied to the COVID-19 operational environment. You can register at the link you see there and also click on the link for more information on the event page. We'll also aim to continue the discussion and, as I said, follow up on some of the many excellent questions that came in that we weren't able to deal with in real time today, but we'd like to follow up with those with our speakers in the discussion forum and in other venues, so you'll be hearing from us about other follow-up opportunities soon. With that, I'd like to thank everyone, both our panelists, our participants, for a very interesting discussion, as well as the technical teams and substance teams behind the scenes for putting this all together today. Thank you so much, and looking forward to connecting with you again in the near future. This is Ann Herod Lang signing off from Geneva.